Hi everybody, this is Dr. Ihab Abdurrahman Ihab Tarawa, consultant for care medicine at Soba University Hospital, professor of medicine, University of Khartoum. We are still doing our session in medication safety course, introduction to medication without harm. This session is about polypharmacy. Objectives define polypharmacy, differentiate between appropriate or inappropriate polypharmacy, discuss clinical risk and economic burden associated with polypharmacy, implement measures to reduce the risk of polypharmacy. Polypharmacy, there is no standard definition. Polypharmacy is the concurrent use of multiple medications. Polypharmacy is often defined as the routine use of 5 or more medications. These include over-the-counter, prescription, and traditional complementary medicine. Polypharmacy could be appropriate or inappropriate. Appropriate polypharmacy is present when all medications are prescribed for the purpose of achieving specific therapeutic objectives that have been agreed with the patient. Therapeutic objectives are actually being achieved, or there is a reasonable chance they will be achieved in the future. Medication therapy has been optimized to minimize the risk of adverse drug reaction, and the patient is motivated and able to take all medication as intended. Inappropriate polypharmacy is present when one or more medicine are prescribed that are not or no longer needed, either because there is no evidence-based indication, the indication has expired, or the dose is unnecessarily high. One or more medicine fail to achieve therapeutic objective and they are intended to achieve. One or the combination of several medication cause adverse drug reaction, and put the patient at high risk for adverse drug reaction. Patient not willing or not able to take the medication as intended. Let us reflect a little bit on polypharmacy. Traditionally, both medical research and healthcare delivery model, it focus on single disease intervention. Most of the randomized control trial, they select certain group of people with multiple comorbidities and multiple polypharmacy most of the time are excluded from randomized control trial, so there is no significant evidence. Consequently, there has been notable lack of evidence-based solution. Conventionally, polypharmacy has been perceived as an overuse of medicine, whereas it may be more useful to perceive it in terms of appropriateness, as there are many cases where the concurrent use of multiple medication may be deemed necessary. For example, someone with diabetes and ischemic heart disease, they might need to be in many anti-ischemic medications. They could be an aspirin, beta blocker, ACE inhibitor, nitrate, plus a couple of diabetic medication. Globally, the prevalence of polypharmacy is set to rise as the population age and more people suffer more from multiple long-term conditions. Polypharmacy carries significant risk to the patient. Most vulnerable patient group to the risk of polypharmacy are susceptible to drug-drug interaction, drug-disease interaction. They should be a risk for fall, high risk for fall, adverse drug reaction. Some people, they get cognitive impairment, and some patients, they do not take medication. Non-adherence is an issue, poor nutritional status. Vulnerable patient group often include all patients over the age of 65 and patients on living nursing home or live-in care home. Multimorbidity is defined as presence of 2 or more long-term health conditions, which can include defined physical and mental conditions such as diabetes and schizophrenia. ongoing conditions such as learning disability, symptom complex such as frailty and chronic pain, sensory impairment such as sight or hearing loss, and alcohol and substance misuse. It has been estimated that the global population age over 65 year will double from 8% in 2010 to 16% in 2050. In 2015, approximately 5% of the population were age 80 years and above. This percentage is expected to rise more than double by 2050. And multimorbidity, it increases with age. In a Scottish study, multimorbidity was prevalent in 81.5 of individual age 85 and over. The mean number are 3.6 morbidities. Ornstein found that most prevalent chronic condition in primary care were hypertension, hyperlipidemia, and depression. Economic impact of polypharmacy, it is estimated that mismanaged polypharmacy contribute to 4% of worldly total avoidable costs due to suboptimal medicine use. The total US 18 billion, which is 0.3% of global total health expenditure, could be avoided by appropriate polypharmacy management. Incidence of patient reported error increases with the number of medications that were taken. 30% of patients taking five medication or more experience adverse reaction or harm. 47% of patients taking 10 or more medication. Polypharmacy may have harmful implication of patients such as an increased risk of medication error, drug interaction, suboptimal patient adherence, and reduced quality of life. Polypharmacy is carry risk in the transitional zone. When patients move across care setting, medication reconciliation is an important issue that need to be addressed. Systemic review of hospital-based medication reconciliation practice showed consistent reduction in medication discrepancy, potential adverse event, and adverse drug event after medication reconciliation, with the most success seen in high-risk patient populations such as those on polypharmacy. Discrepancy in medication order are common and they increase with number of medication prescribed. A study of post-discharge patients found that almost 1/5 of currently used prescription medicine had not been recorded during hospitalization, and that less than half of the medication used has been registered in patient discharge letter. Nursing home resident, up to 40% of prescription for nursing home resident may be inappropriate or suboptimal. It was found that average care home resident in England was taking 8 medication per day, and over 2/3 of these residents had one or more medication error. Inappropriate prescribing contribute towards medication burden and exacerbate the problem of inappropriate polypharmacy. Over-the-counter medication is also an issue. Non-steroidal anti-inflammatory and some medication for allergy, cough interact with prescribed medication. Traditional and complementary medicine also contribute. The use of herbal medicine is widespread and taken by many patients. It can interfere with many drugs. One of the ways to help is to do medication review. It provides structured evaluation that can be used to prevent harm optimize treatment, and improve outcome by optimizing the use of medicine for each individual patient. Where possible, medication review should be performed in collaboration with the patient and caregiver. We should involve them, we should get them engaged so they can, you can learn from them and you can educate them and teach them. Pharmacy-led medication review can reduce hospital readmission. Patients who receive medication review were followed for 12 months and they experienced 16% fewer hospital visits and 47% fewer visits to the emergency room. In addition, medication-related readmission were reduced by 80%. In medication review, we need to assess the benefit and risk. To facilitate medication review, prescriber need practical tools and information to help with decision making on the safety and effectiveness of medicine and appropriateness of initiating or continuing long-term medication. One useful measure which helps prescriber to understand the probable clinical efficacy of medication is number needed to treat. The number needed to treat can be defined as average number of patients who require to be treated over a time period for one patient to benefit compared with control. It can also be expressed as reciprocal of the absolute risk reduction. The ideal number needed to treat being 1. That is, if you treat 1, you will benefit 1. Also, another tool is to measure the number needed to be harmed, which is the opposite of number needed to be treated. Medication review process in polypharmacy, the perspective of the patient on managing and taking multiple medications should be assessed, as well as patient goal of care. The intention of the patient would need to be aligned with the prescriber view of improving outcome and treatment goals. The information and change drive from medication review should be made available to other healthcare professional and provider, especially as the patient move across different care setting. This is in order to establish collaboration and allow information sharing. When the medication is not appropriate or is harmful or is not necessary, deprescribing should be followed. A structured tool to utilize for medication review: set the aim, what matter to the patient, review diagnosis and identify therapeutic objective, understanding of the goal of medication therapy, management of existing health condition, prevention of future health problem. Need, identify essential medication, and also you need to identify unnecessary medications. Then you assess the effectiveness, are therapeutic objective being achieved, and then you go to achieving of therapeutic effectiveness by symptom control, by biochemical and clinical target, and by preventing disease progression. And you have to assess safety. Does the patient is at risk for adverse drug reaction? Does the patient know what to do if they are ill? So the patient need to know about drug interaction, drug disease interaction, and they need to know how to handle medication when they are sick and what to do if they missed a dose. And then cost appropriateness is also necessary. And finally, patient-centeredness, the patient willing and able to take medication as intended, and this is need to be assessed and addressed. Some factors that can help to improve polypharmacy is to give patient a patient medication list, what we call medication passport, and also we give them information about the medication, their indications, their use, and also how to manage sick days, and they should take the 5 moments for medication safety. Whenever they start a new medication or stop a medication or medication is added, they need to reflect and they need to ask the provider about the indication and the dose and frequency and all other information related to medication. For the provider, professional education and capacity building can help to reduce the polypharmacy. Medication review should be done frequently, maybe every 6 months or every year. Sharing output of medication review with the patient and caregiver and other healthcare care provider, and utilize human factor in process design. Take home, polypharmacy is associated with significant medication-related harm. Medication review can help to de-prescribe unnecessary medication. Decision-making tool and patient engagement are important in reducing harm related to polypharmacy. Thank you.